Good afternoon, everyone, and welcome to today's ToxTime webinar titled Identifying and Helping Newborns Affected by Alcohol and Other Drug Misuse. USDTL is delighted to introduce our esteemed guest speakers today. First off is Guida Brown, whose academic journey has made an impact in the nonprofit sector in the Kenosha, Wisconsin area and far beyond. Guida has dedicated her life to empowering individuals and communities. Her roles include serving as the executive director at Women and Children's Horizons and the Hope Council on Alcohol and Other Drug Abuse. As the principal of Guided by Guida, she continues to guide individuals and organizations using her extensive experience as a substance abuse counselor, fetal alcohol spectrum disorder trainer, and Intoxicated Driver Program Assessor. She is also an esteemed adjunct faculty member at Concordia University, University of Wisconsin-Parkside, and the Gateway Technical College. Guida's journey is a beacon of dedication, knowledge, and compassion. She's inspiring all of us to make meaningful contributions. We are also honored to have Dr. Eileen Baldwin with us today. She is the Assistant Laboratory Director for Research at USDTL. Dr. Baldwin spearheads the research projects on prenatal alcohol and substance exposure. Her educational background is equally impressive, with a doctorate from Northwestern University Medical School's Integrated Graduate Program in the Life Sciences and a Master of Public Health from Feinberg School of Medicine. After her postdoctoral fellowship at the Pasteur Institute in Paris, France, Dr. Baldwin joined the scientific team at USDTL. Her expertise contributes to cutting-edge research and shaping our understanding of critical areas. So, ladies and gentlemen, please join me in welcoming Guida Brown and Dr. Eileen Baldwin.
Hello. Thank you for attending the Identifying and Helping Newborns Affected by Alcohol and Other Drug Misuse ToxTime. I'm Guida Brown, the principal for Guided by Guida. First, let's do a recap of fetal alcohol syndrome. We know that in the United States, alcohol use, and that's any alcohol use, wine, beer, hard liquor, alcohol use during pregnancy is the leading cause of preventable birth defects and intellectual disabilities. It can cause a range of developmental, cognitive, and behavioral problems that can appear at any time during childhood and last a lifetime. And the problems can't be cured, but they can be mitigated, which is why early intervention is vital. So, how much alcohol is safe during pregnancy? There is no safe amount during pregnancy, not during the first trimester, not during the second trimester, not in the third trimester. There's no safe amount of alcohol use during pregnancy. We like to say that the part of the baby that is forming is the part that's going to be most affected when that alcohol use goes on. So, for example, the heart. If somebody drinks alcohol between 3.5 weeks to 9 weeks of pregnancy, the heart is going to be most affected in the baby. The palate, if somebody drinks alcohol from 6.25 weeks, 6.75 weeks to 16 weeks, the palate is going to be most affected. But we also know that drinking at any time during pregnancy can harm the fetus. The fetal brain and central nervous system is particularly susceptible to the teratogenic effects of alcohol as the brain is developing throughout the fetus developing. However, any of these body parts and systems can be affected by alcohol exposure during pregnancy. So these aren't hard and fast time frames that are going to, make sure that the baby's not going to be affected or the heart's not going to be affected during certain. Let me stop a second here and talk about the sort of misnomer of a diagnosis of fetal alcohol spectrum disorder. There is no diagnosis of fetal alcohol spectrum disorder. It's the umbrella term that we use, and it's just simply a shortcut. So we can diagnose and treat fetal. the fetal alcohol spectrum disorders, but it's not specifically that. So we have other names that fall under it. The primary disorder that we notice is fetal alcohol syndrome. And I'm going to get to that in a second, but no cure exists for fetal alcohol spectrum disorders, but early diagnosis and implementation of interventions can significantly reduce the effects and improve developmental outcomes. So that early intervention really makes a difference. To diagnose fetal alcohol spectrum disorders, doctors look for fetal abnormal facial features, the dysmorphic effects of the alcohol in the face, lower than average weight or height, central nervous system problems that include a small head size or problems with attention, hyperactivity, poor coordination, and evidence of prenatal alcohol exposure. But I will say that in the United States, for a diagnosis of fetal alcohol syndrome, the full syndrome, that evidence of prenatal alcohol exposure is not required. So when we see babies that have these facial features, these dysmorphic features of the low nasal bridge, or the flat mid face with a short nose, or the thin upper lip based on other family members, or the indistinct philtrum, the two lines between your nose and your lip. When we see a baby that has those features, that tends to lead to a fetal alcohol syndrome diagnosis. However, there is not one feature here that is specific only to fetal alcohol syndrome. So if somebody is missing their philtrum, it doesn't automatically say they have fetal alcohol syndrome. There are other disorders that can look the same, which is why in part why diagnosis is hard. The other part why diagnosis is so hard is because we don't talk about it. We aren't doing a great job of making sure that people aren't drinking during pregnancy. We don't even talk about that, let alone the idea that how unsafe it is and the lifetime effects. So we really have to do a better job of that, but we also have to do a better job of determining whether or not talking about it has done any good. So I'll get to that. Alcohol use during pregnancy can lead to lifelong effects. 5% of the population is estimated to have a fetal alcohol spectrum disorder. That's 1 in 20 people. And I just want you to think about, do you know anybody who has a diagnosis of fetal alcohol syndrome or fetal alcohol effects or alcohol-related birth defects? 1 in 20 people, we believe, and I would say that number is actually low. 1 in 20 people have fetal alcohol spectrum disorders. Out of all the people you know, have you ever met somebody who's had one of those diagnoses? And I would say, unless you're pretty involved in this field, that answer is no. We are not doing a great job of diagnosing them. So that leads to misdiagnosis, that leads to underdiagnosis, that leads to no diagnosis. And that's a lifetime of frustration for the people with the fetal alcohol spectrum disorders, as well as for those people who love them. I liken this to treating a cough when somebody has pneumonia. We find one thing. So in the behavioral and intellectual disabilities on this list, we find hyperactivity, or we find attention deficit, and we treat that. We have a pill for that, which makes it a lot easier than just saying, this child has this whole gamut of disorders. So we have a pill for it, we treat that, but that's like treating a cough when somebody has pneumonia. We're not doing a great job of looking at the whole big problem. And in doing that, we're really short-sighted in how we can help in the big picture. So a person with a fetal alcohol spectrum disorder can experience a mix of the following problems. They can have a lot of physical issues like the low birth weight and growth, problems with organs, damage to parts of the brain. Fetal alcohol use causes brain damage. That's exactly what it is. And that's why it's a lifelong effect. That leads to these behavioral and intellectual disabilities. These are not the be all and the end all. Not everyone who has a fetal alcohol spectrum disorder will have these, and certainly not everyone who has one will have all of these. But there are learning disabilities, low IQ, again, that hyperactivity, the attention deficit, poor ability to communicate in social situations. They don't follow social cues very well. They have poor reasoning and judgment skills, which leads to their being taken advantage of. They end up dying by suicide earlier. They end up at young ages. They end up having underage pregnancies, teen pregnancies. They end up with substance use disorders. They end up being victims of crime, and they end up committing crimes. They have poor social skills. They have a difficult time living independently because they don't understand abstract concepts like time and money and laws. And so keeping a job is not very feasible oftentimes because they don't understand what time they have to be to work. I liken it to talking to my grandkids and them, saying, what time can we leave? And I say, we can leave in one SpongeBob, because they can't understand 30 minutes, but they can understand how long-ish a SpongeBob is. The trouble with the law, when I'm in a group in person doing a training like this, I will say to somebody in the room, hey, can I have your phone? And they will invariably hand me their phone, and I'll take it and I'll say, okay, now it's mine. That's how a lack of abstract thinking works. And so the trouble with the law is not necessarily big crimes, but petty crimes that happen over and over and make them look like they're doing misbehaviors on purpose, and they're not. They have a hard time following rules because they don't understand them. They're abstract, and they don't have great retention. So oftentimes, even talking to a child will say, all right, it's time for bed. You need to, clean up your mess and go brush your teeth and put your pajamas on and you go to bed. And you find that they have brushed their teeth and now they're sitting in their bedrooms playing a video game. And that seems like they're doing that on purpose. But the fact of the matter is they lost track of all the rules. And so we see that even in grown-ups who have fetal alcohol spectrum disorders. And again, because we are not diagnosing them, we're treating them like it's willful disobedience. Thus, they end up incarcerated in so many situations. Drinking while pregnant costs the US $5.5 billion per year. And I would contend that that number is low because we don't know who's drinking while pregnant. And cannabis is no better. So we still have doctors who are saying, oh, it's okay to smoke while you are pregnant, especially to females, the maternals. But we know now that that is not accurate. Both paternal and maternal cannabis use is causing problems with fetus. There's spontaneous abortion, miscarriage caused by the paternal use. Both cause low birth weight. Maternal use is causing premature birth and altered fetal epigenomes. Offspring for both is small gestational age. Paternal use is causing sudden infant death syndrome. Maternal use is causing additional NICU admissions, autism spectrum disorder diagnoses, attention deficit hyperactivity disorder diagnoses, and psychotic-like experiences. And so we have to make it clear that using substances during pregnancy is not a good outcome for the neonate. I am old enough to remember the cocaine mom crisis and the fact that that was going to be the end of society as we knew it. And that was in the late 80s, early 90s. And we found out that it really wasn't the cocaine, it was the alcohol. I think that's another thing to consider. Very often, a person who is using one substance is using other substances, especially alcohol, because alcohol is very socially acceptable and very accessible. And so I'm concerned. So 50 years ago, we discovered that alcohol use during pregnancy is problematic. And I'm afraid that in 50 years, we're still going to be talking about how cannabis use during pregnancy is problematic. And we may still be talking about how alcohol use is, because again, we have not done a great job of helping people do better when in pregnancy, or helping the babies do better once they're born with the effects. So we ask them, right? We say, hey, are you drinking during pregnancy? And asking isn't working. A 2020 Morbidity and Mortality Weekly Report article stated the CDC scientists found that about 10% of pregnant women reported current alcohol use. And of that 10%, 40% of them reported use of one or more other substances. So again, 10% said, yes, I'm using alcohol. Of that, 40% said, I am also using one or two other substances. But USDTL, US Drug Testing Laboratories, did further research and found that a full 18% more pregnant people use one or more other substances, showing that simply asking doesn't work. Nearly 1 out of 5 pregnant people who are using alcohol are underreporting their use of other substances. So I would think that if 1 out of 5 is underreporting other substances, a fair number of people are underreporting their alcohol use in the first place. So asking just isn't helping. It isn't solving the problem. And that's why direct biomarker testing is so important. We say that we believe that addiction is a disease, so we have to treat it as such. We don't ask somebody with diabetes, hey, how do you think you're feeling with your insulin? We test for it. We don't ask somebody who is on warfarin because of heart problems. We don't say, hey, how do you think your INR is? We test for it. And so we have these great tests. We just have to use them more. If we really want to know how someone with addiction is doing, we have to test. We have the tools to do that, both for the individual who's using the substances and for the newborns. We can use their umbilical cord. I think, there's a reluctance oftentimes to test because of our system being punitive. When somebody has a positive test, somehow that causes negative consequences. And I have a huge problem with that. Again, if we believe that addiction is a disease, then there shouldn't be negative consequences for a test that shows I'm suffering from this disease. My sister has diabetes. She doesn't show up at the nutritionist office and show her pump report and get in trouble for not being able to manage her sugar levels. My husband has a heart problem and he takes warfarin. He doesn't get in trouble when he goes to the doctor's office because his INR was not managed properly or because it spiked. Neither one of them get random calls to say, hey, you have to rush down to the hospital in the next 24 hours to get a test. We help them manage their diseases. And if we believe that addiction is a disease, we have to help people manage those as well. I came across a listing for the worst outcomes for births in the States. So of the top 9 worst states for birth outcomes, 4 of them also have the worst drug use by state and the worst death by excess alcohol by state. So 4 states are the same. 4 of the top 9 states are the same across the board for worst birth outcomes, most drug use by state, and most death by excess alcohol. And I'm not saying that I can prove that there's a cause and effect here, But I do think that somebody would be able to prove this if we were doing better testing. If we were doing umbilical cord testing of neonates, I think that would allow for better outcomes for birth, which is what everybody wants. If everybody were on the same page and we knew what was going on, and again, if addiction is a disease, let's not penalize the people who are suffering from the disease. And so there is part of the stigma that goes along with addiction as a disease has that negative bias to it. And we'll talk about that in a bit. Screening newborns for alcohol exposure, what are the benefits? Well, we believe that for every dollar spent, we may be saving up to $97. Again, we need to diagnose it early. We need to be able to distinguish what they have and give them referrals early on instead of waiting later and later in life. Think about every single classroom having a child who has a fetal alcohol spectrum disorder. Milder cases are harder to diagnose, so we need more diagnosticians. We need to talk about this. We need to be able to identify it. And we really need to help pregnant people who have drank during their pregnancy. Again, I'm sorry, I can't overstate how we're doing them such a disservice by acting like it's not a problem because we don't have the right questions or the right answers or the right attempt to show them how the problem can be mitigated. I want to draw your attention to the annual cost estimates. I think it's a little wonky in that annual cost estimates are from 75 million to 4 billion per year for fetal alcohol spectrum disorders. And I would say that's a huge range, right? 75 million to 4 billion. I would say that because of the underdiagnosis, we have no real idea what fetal alcohol spectrum disorder is costing our country. And if every child who actually had a fetal alcohol spectrum disorder had a diagnosis for it, I would say that 4 billion would be low right now. I think we are spending a lot more and we just don't know because, again, we're treating a cough when somebody has pneumonia. So now what? Early intervention is a term used to describe services and supports that are available to families with babies and young children with developmental delays and disabilities. And no referral is necessary. So what I mean by that is it can be a self-referral. Someone can just call their early intervention program that exists in every single state. They can call and say, I believe that my baby has a developmental delay. I need an assessment. And they will be able to get in for free or a reduced cost for any baby that is eligible, any child. So it's birth to 3 typically. Those services can include speech therapy, physical therapy, other types of services. I mentioned we have to have this wraparound of services for the family, for the child, but we have to be able to recognize it. We're doing a terrible job of just recognizing it. We need to, the CDC has this great website. All you have to do is look at it, Google your state, and it will tell you who your early intervention program is for your state, where it's run out of, and for your county as well. Everyone has access to early intervention in their states. We just need to use it. I know that where I'm from, I know exactly who to call, but they don't get referrals for fetal alcohol spectrum disorders. And again, it's because they're not getting diagnosed. So these children, these babies, these infants who can get services aren't getting services. They aren't having early interventions, which is causing problems long-term for longer and more drastic. And so we really have to start doing a better job of recognizing the need early on and then making those referrals. So I want to talk a little bit about CAPTA. CAPTA is the Child Abuse Prevention and Treatment Act, and it was originally enacted in 1974. In 1974. So from 1974 until 2016, we were preventing child abuse. We were preventing child abuse and getting into treatment. Children and their families who were born and identified as being affected by substance use or withdrawal symptoms. And somehow we completely left out fetal alcohol spectrum disorders or alcohol use in that. So it became, we knew what to do with neonatal abstinence syndrome or neonatal opioid withdrawal syndrome. And so that's what this got focused on. So in 2016, which I think is really late, in 2016, we finally got added into CAPTA that it also is for fetal alcohol spectrum disorders. Now, the problem with that was a great step in the right direction. But the problem with that is I've already told you ad nauseum, we're not diagnosing fetal alcohol spectrum disorders, right? We're not getting those referrals. We don't know that it's happening. So if we were doing umbilical cord testing, we would know this, and we would have a better idea of what to do with neonates who are born with alcohol in their system. But CAPTA has been looked at every single year. They've considered taking out fetal alcohol spectrum disorders and changing it to those who are affected by substance use disorder, including alcohol use disorder. Again, because fetal alcohol spectrum disorder isn't a diagnosis, and diagnosis of alcohol-related birth defects or disorders are difficult to make in neonates. They're difficult to make. They're not being made, and it ended up being a really vicious cycle to not help babies being born with alcohol in their systems. Further changes being considered aim to support rather than penalize families, highlighting the importance of equitable family assessment and re-examining existing state laws that are punitive. Too many states are saying that substance use during pregnancy is child abuse, and I'm not saying it's not child abuse. I'm saying that if we treat it like it's a disease, then we really have to do more. We really have to make sure that the person with the disease is getting help in addition to the person who has been abused, if that's how we want to look at it. We can't just, lock somebody up and say, well, there you go. And now this child, this baby, this neonate that still doesn't even have a diagnosis, or maybe has a diagnosis of one thing, is put into a system that is not equipped. Our foster care system is not equipped to deal with children who have fetal alcohol spectrum disorders any better than our schools are, any better than our general population is, because we just haven't done a great job with it. So we have to do better. CAPTA has made a couple inches forward, but we still have to do so much better when it comes to our neonates. How do we do that? Well, get involved. Is your state on the map? Do you have an FASD state proclamation? If you don't, talk to your governor, talk to your people to make sure you do. Fetal alcohol spectrum disorder is now 50 years old. We've been addressing this for 50 years, and this proclamation map is pathetic. When again, 5% of our population is affected by fetal alcohol spectrum disorders. This is I can't think of another disorder that people don't rally around like they don't rally around this. So get involved. Follow FASD United. Follow their website. Follow their Facebook page. Make sure that you learn about what you can do specifically in the month of September. They're having an advocacy week in DC for September, but figure out what you can do the whole year. They've got great links to what all of us can do, how all of us can talk about it. Wear your red shoes in all of September. Wear your red shoes. I mean, just get people to start talking about this and thinking about this. But again, FASD United has great resources on their website to help us get the word out about FASDs. Get involved with your state's affiliates. Again, FASD United has a great website that shows who your affiliates are, and then learn more about direct biomarker testing from US drug testing laboratories. Again, testing individuals who have substance use disorders, who need to be in recovery, as well as testing neonates with umbilical cord tests, because that's how we're going to know if they're affected early on, and that knowing early on is going to lead to way better interventions. I gave you all the references. I know some of them aren't real sciencey, but some of them are really good. And again, if you don't look at anything else on here, I encourage you to look at the FASD United website, because they have some really great information there. And that's it. I'll entertain any questions. Thank you so much.
All right. So again, thank you, Guida. Great presentation, great information and insight there. We definitely appreciate that. At this time, we are going to open the platform up for some questions for Guida and Dr. Baldwin. Guida and Dr. Baldwin, if you are ready, the first one is going to be, what challenges do healthcare providers typically encounter when identifying and managing newborns with FASD?
I can answer that for you. So one of the things that Guida talked about in the presentation is that fetal alcohol spectrum disorders is this umbrella term to include a lot of different disorders that each kind of have their own significance. And the fetal alcohol syndrome, which includes the facial features that would be readily identifiable at a young age or even at birth, makes up less than 10% of those affected under that umbrella term. So there's other disorders, alcohol-related neurodevelopmental disorders. So those kids probably, might have shorter height, which isn't something that you would typically pick up right away. You wouldn't really start to identify, some of these risk factors until they're at an age when they start to manifest behavioral issues or learning issues. Maybe they're shorter than some of their classmates. And so this is what makes diagnosis a little trickier, and why we also see some misdiagnoses with other disorders. There's a lot of research that's going into trying to distinguish kids who have FASD versus ADHD and trying to help clinicians make that distinction.
All right, thank you for that. Next question is, are there resources for parents to inform and prevent alcohol and other drug misuse during pregnancy?
Yeah, for my research, I use a lot the CDC webpage. They have web pages for both information about drinking during pregnancy. They also have a really nice page about FASD that includes information about all the disorders under the FASD umbrella. They have resources for healthcare providers, for parents, for people with FASDs. And I find that that's really one good place to go for a multitude of different resources.
Are there specific alcohol biomarker tests for all pregnant women?
Urine ethyl glucuronide, ethyl sulfate is one that has a detection window of about 3 days. And there's also phosphatidylethanol, which is measured in red blood. So it's either from a dried blood spot, which is easy to collect, or from a tube collection of blood.
One more here. How early can fetal alcohol syndrome be identified?
Like that. So Unfortunately, it's not being identified at all, because that under 10% has what we call the full-blown fetal alcohol syndrome. So if 1 in 20 infants is born with fetal alcohol spectrum disorders, and only 10% of those have the dysmorphic facial features, then those are typically the ones that we're focusing on. As Dr. Baldwin said, we tend not to see these things until there are more behavioral aspects going on. But the other thing, in the United States, fetal alcohol syndrome, the full-blown syndrome, does not need a report of maternal alcohol use in order to get the diagnosis, which is good because many parent figures aren't reporting alcohol use. It's bad because wouldn't it be a lot easier to determine what's going on if in fact we had a report of maternal alcohol use? So, I mean, it's sort of a double-edged sword, especially showing up in the foster care system where there's something going on, but we don't know what it is because we don't know what the family of origin brought into this. And so those diagnoses can happen. We just need that whole world of care around them. And unfortunately, I feel like I said this a million times, we're doing a terrible job. I don't know what else to say. So we need more people talking about it and identifying it and looking at it and not necessarily even diagnosing it, right? I'm not a diagnostician. I'm not qualified to be a diagnostician, but I can tell you if I walk into a restaurant and I see a child who has full-blown FAS, I absolutely can see that just from being around me. So can my husband. So we need more people who are qualified to be diagnosticians to start talking about it, and we need more resources to do something about it.
Yeah, and just to reiterate the importance of early screening, I know you mentioned during your talk the importance of early interventions and what early identification can do for these kids. And I think it's really important because, there's so much research going on looking at what can help these kids. Kids' brains are forming from fetal development through early adolescence, and so there's so many different things, even just being placed into a loving household. If a parent knew that, a lot of people drink during pregnancy before they know they're pregnant. If they knew that, and, just knowing that a loving, nurturing environment, can help ameliorate some of these behavioral and learning disabilities, and just trying to get these kids diagnosed early is just so important to their development.
Great information there. This is kind of a long one here. If we don't really diagnose this issue, how do we know or advocate for families who have it? For instance, if we have a 19-year-old that is consistently in trouble with the law, he was not diagnosed as a child, how do we know that this may be the cause? So I guess kind of combining all that is, is there a way to diagnose this in later childhood or adulthood?
Yeah, there is. Again, we don't have enough diagnosticians, but if you find somebody who's interested in your community, that can be done. I went to a conference and Washington State seems to have one diagnostician. Wisconsin has one diagnostician, especially for adults, but it can be diagnosed. So I would say, learn what your resources are. Again, talk about this. It's not that the training itself is seriously one day. So people who are diagnosticians, people who are qualified, which are doctors, people who can write scripts, can learn to diagnose. The problem is it's scary when you're like on an island and imagine how many people you would have to see because it's so prevalent without any diagnosis. So it can be, I would say probably every state or nearly every state can diagnose adults with FASD or FAS. Our system of incarceration is filled with people who have FASDs who have not been diagnosed, filled with. I joke that my next mission is to go in with a diagnostician and ask and do a screening on everybody in our system of incarceration, because at least then we'd have a better sense of how many numbers we are dealing with, because again, we're just not doing a great job.
Interesting. Good insight there. One other question: is the male sperm quality compromised by drinking, and does it impact or contribute to FASD?
I would say as a researcher and as a mother, I find this a very fascinating question. I think it's a really, really interesting, kind of newish area of research in the FASD research world. Mainly because when we talk about, maternal fetal health, we're kind of forgetting that 50% of that fetus's DNA came from dad. So why is it not maternal, paternal fetal health? And yes, there have been research studies that have shown, mainly, I think actually all in animal models, showing that the male contribution both can impact sperm quality, and that there also might be some genetic and epigenetic factors associated with males who drink. And I think it's really important too, because, you look at the CDC numbers, and typically, year by year, men drink more and at higher quantities than women do. And so I think that more research looking at the paternal impacts and their association with FASD would be really good. Also in kind of removing this stigma that, it's solely mom's contributions to fetal health.
What are your thoughts about breastfeeding infants whose mothers who use cannabis?
Unfortunately, there's not a ton of research that has looked at the impact. So THC, the psychoactive component of marijuana, is lipid soluble. So fat is the last place that it leaves the body from. It really sticks to fat. And so breast milk is extremely fatty. So I do think that THC probably does collect at pretty high quantities in breast milk. But unfortunately, there's just not a lot of research that looks specifically at, quantities of how much a mother is smoking during breastfeeding, and then how that impacts the child's development.
I just want to point out again, I don't know that we're doing a great job of clarifying what's appropriate, right? If I know that there are still doctors saying, oh, it's okay to smoke a little weed during pregnancy, it might make your birth easier. We had, up until 5 years ago, we had doctors saying it's okay to have a glass of wine during pregnancy. And so just, I think about the Zika virus. If everyone remembers the Zika virus, and every pregnant woman was warned not to get stung by a mosquito, bit by a mosquito. And the chance of getting the Zika virus was minuscule, but we spent more energy on that than we did talking about drinking during pregnancy. And so again, I just think that we need to do a better campaign. We need to do a better campaign to talk about what's safe during pregnancy.
So if mom has a glass of wine occasionally throughout pregnancy, would that be detected in the umbilical cord?
I think that's a good question. I guess one question would be, what does the woman consider a glass of wine? What quantity of wine? And what is occasionally to someone? Occasionally to someone might be, a half a bottle of wine a night, just 1.5 glasses a night. That's all. But if it was actually very infrequent consumption of a very small quantity, it probably would not be detected at umbilical cord. I know from research that I have done, we saw about 2% positivity in an at-risk population, where we knew maybe 10% of the moms were drinking. So if you look at the CDC numbers, where they say 10% to 14% of moms say that they drink during pregnancy, and 2% say that they drink heavily, the umbilical cord ETG kind of the prevalence rates would suggest that it's not just occasional drinking, that it's more likely to be heavier drinking.
Appreciate the insight, Guida and Dr. Baldwin. Looks like, one other question just came in. Let's see. So is there any research to establish how much use is correlated to detection?
Well, I can talk about detection in the mother, and it depends on what the test is and what's going on. So we know that if somebody is consistently drinking a glass, that will show up in a PEth, in a PETH blood spot, 1 glass a night. Over that, it will show up in likely in all of this, but again, I think the bigger question is the measurement of it, because when I say, oh, I do assessments as part of a job I have. And so I say, what were you drink? How many drinks did you have? And they say, I had 1 drink. And I said, oh, well, what were you drinking? Well, it was a Long Island iced tea. That's not 1 drink. That's at least 4, possibly 5. And so we don't have really hard and fast numbers, but drinking during pregnancy is bad.
And I think one of the other aspects that the CDC touches on is that typically those moms that are drinking are using other substances. I believe the number, Guida, was 40% of moms that are drinking during pregnancy are using another substance. And so that's also the nice thing about doing a matrix like umbilical cord, because you will identify those polysubstance exposures, which are also detrimental to fetal development.
Well, and 40% are saying they're using other substances, and 58% are actually using other substances. So pretty significant differential there.
Mm-hmm.
So I know we are coming up on our allotted time. Obviously, if we did not get to your question today, please know that we will reach out and answer any of those questions still remaining. Again, quick note, USDTL, we will be attending and exhibiting some conferences coming up. The next one is going to be the National Mother Baby Nurses Conference, which is actually next week in Las Vegas. We have the Perinatal Substance Use Conference coming up later in September, as well as the National Association of Neonatal Nurses Conferences. You may have seen this in one of the slides at the very beginning of our webinar, but USDTL is excited to announce the xylazine testing in umbilical cord tissue. So if there is any questions on that, you want some additional info, by all means, feel free to reach out, and we will be more than happy to provide that information. Again, to keep up with any latest events and USDTL news, we do encourage you to visit our website. Also join our mailing list. We are on LinkedIn, Facebook, YouTube, and Twitter. And again, we hope everyone has enjoyed today's presentation. Thank you, Guida. Thank you, Dr. Baldwin. And thank you, everyone, for joining us. And we hope you have a great day.
Subscribe to our channel and visit our website for more information.